Thank you so much for joining us on today's webinar, Scientific Public Health and Lived Experience Rationale for Expanding and Early Hepatitis B Treatment. Today, we have a really packed agenda with excellent speakers, and I'm pleased to have you here with us. Welcome to everyone for joining. My name is Catherine Freeland. I'm the Associate Director of Public Health Research at the Hepatitis B Foundation, and I'll be moderating today's session. I'd want to start off by just sharing a bit about how you can participate in today's webinar. Attendees are all in mute. If you would like to speak, you can use the chat feature, the raise hand feature, or you can use the Q&A feature throughout the webinar, and we'll be moderating the Q&A and the chat. And be sure to make sure panelists receive any questions that you have throughout the webinar. You can use the chat feature to also introduce yourself at this time. We would love to hear from you and where you're calling in from today. Just to share a little bit about an overview of the agenda, we'll be starting with Dr. John Tavis, who will be talking about why expanded treatment papers were written and the justification for those. Then it'll be followed by Dr. Patrick Kennedy, who will be talking about expansion of treatment, followed by Dr. Sherry Cohen discussing the patient public health perspectives for expansion of treatment. And then there'll be a panel discussion with several of our speakers today. And you'll have the opportunity to ask questions during the panel session specifically. Just to give you an overview of who will be speaking today briefly, our panelists, Dr. Sherry Cohen, who's the president of the Hepatitis B Foundation, Dr. Patrick Kennedy, who's the chair of the British Viral Hepatitis Group and former lead for the British Association for the Study of Liver Disease and Special Interest Group in HBV. Dr. John Tavis, who's a professor of medical virology at St. Louis University School of Medicine and director of the St. Louis University Institute for Drug and Biotherapeutic Innovation. Dr. Thomas Tu, who's an associate professor at Westmead Institute for Medical Research at Storr Liver Center. And finally, Dr. Sue Wong, who's the medical director for the Center for Asian Health Viral Hepatitis Programs at Cooperman Barnabas Medical Center and associate professor at Rutgers, New Jersey Medical School. To kick us off today, I'd like to turn it over to Dr. Tavis, who will be discussing why the expanded treatment papers were written. Dr. Tavis, over to you.
Thank you very much, Catherine. Just to get started, I'll have a very brief presentation to give some context about the etiology of these papers. Next slide, please. And again, next slide, please. Okay, so first off, I want to introduce the organization called ICE-HBV. ICE-HBV stands for the International Coalition to Eliminate HBV, and it's a international coalition of a number of most of the leaders in HBV virology, immunology, and technology, and early stage drug development. And our goal is to really inject some really high quality science into the discussion around curing HBV and how to go about it, and also to share scientifically vetted, accurate, and up-to-date information with the afflicted communities. And so in short, ICE-HBV is the voice of the basic and early stage translational HBV research community for scientific policy and public lobbying. If you want to learn more about us, there's the website there. So why did we commission these papers in the first place? Well, it really boils down to a very simple fact. People living with HBV need better care, and they need better care right now, which means we can't wait for new drugs to come along. And so many of us in the field, I'm coming at it from a molecular virologist perspective, are looking at the accruing data and are saying, well, golly, damage to the liver is occurring and accumulating during infection long before we start treating most patients. And then you have the physicians, many of them who are sitting there looking at it going, I put HBV on these patients on these nucleoside analogs, and they do better, but I can't give them to everybody because the guidelines don't allow us to do so. And so just a bunch of us who were feeling that got together through ICE-HBV and thought, well, let's see why. Let's see if we can find the rationale for what's going on here. And so, underlying facts are the nucleotide analogs, such as entecavir or tenofovir, that are the dominant therapies. They're really good. They reduce disease and they reduce death rates, not as much as we want, but they're good. They improve the quality of the life for patients, and in the vast majority of people, they're affordable and safe. And so treatment eligibility is currently limited by treatment guidelines that require high HBV DNA levels and overt disease. These are the endpoints that can be readily measured in a clinical HBV trial that can be done in a reasonable period of time and done ethically without having to do a long-term placebo-controlled trial. But they inherently look at short-term outcomes rather than the long-term major health impacts that occur during an HBV infection that can take 20 or 30 or 40 years to accrue. And and again, the new therapies are coming, but they're going to take a while. I mean, the optimistic look is that we'll start getting things hitting the market in maybe 4 years that will be incremental improvements, and getting to widespread functional cure is going to take quite a while. And even when they do come out, the patients in low and middle income countries are going to have to wait even much longer because they're going to be expensive and complex until we figure out how to get them into resource limited areas. And of course, China and the WHO had just loosened their treatment guidelines to some degree. So next slide, please. And so that led us to ask the question is, what does the science really say about expanding the treatment guidelines? Next slide, please. So how did we go about writing the papers? So a bunch of us from ICE-HBV got together and we noodled around for a little bit thinking about it. And we determined that the scope of this topic was so large that it needed two companion papers. So once that was decided, we recruited leading basics, translational, social, and clinical scientists and formed two writing teams. And all of the members on the panel that will be speaking today were on one or both of those writing teams. We then worked collaboratively to generate the outlines for the papers. Then we dug into the literature and dug into our own experience and researched the topic, wrote drafts, went around and around and around. And finally, we got some decent drafts that looked like they were ready for submission. Both teams reviewed them and put impact into the other paper. And this whole in-depth process took from June 2023 to July of 2025. So this was a 2-year concerted effort of hard work by quite a large number of people. So next slide, please. And the key point is here is we examined the full scope of the available data addressing what earlier or broader treatment of the HBV infected community would be, not just the clinical data that reach the gold standard requirements that dominate clinical guideline writing. So we took a very holistic view on everything. And with that, just another plug for ICE-HBV, and I will hand it back to the rest of the team to go over what our observations and conclusions were. Thank you very much.
Great. Thank you so much, Dr. Tavis, for that excellent overview. Now I'll turn it over to Dr. Patrick Kennedy, who will be discussing takeaways for the scientific rationale for expansion of hepatitis B treatment guidelines. So over to you, Dr. Kennedy.
Thanks, Catherine. Next slide, please. So, I mean, this is really just the title slide to just go over some of the elements that I'll be discussing over the few slides here, really looking at some of this scientific rationale that John was referring to. And really, when I look at chronic hepatitis B, I really always think about hepatitis B as an oncogenic virus. And I think that's a critical thing, certainly for a physician like me in the clinic when we're meeting people living with hepatitis B coming into the clinic all the time, new diagnosis. And we want to see how we can, in some way, improve quality of life, all of those things that you just heard John talking about. And I'm going to give you some of the reasons why I think these two recent papers have been so important in helping move the field forward. So this takes us back to 2006, the REVEAL study, which is a really important or landmark study in chronic hepatitis B. And essentially, because these individuals studied in Taiwan, we were able to make some of the first observations that level of viremia was directly related to cumulative deaths, complications of chronic hepatitis B, and liver cancer. And if you look across the x-axis here, what you're actually seeing is you're seeing HBV DNA actually expressed in copies per ml. This will give you an idea how old this paper is. But essentially, if you divide those numbers by 5 and you start at the second column, you're looking at, when you're getting to 2000 IU, you're certainly seeing some indication that there's the potential for the development of liver cancer. And as you move further across with higher levels of viral load, you can see that there's an increase in the development of liver cancer in these individuals in untreated patients from these revealed data. Next slide, please. And John also talked very eloquently about why we felt we needed to, write these papers and to really push this subject matter to the fore. And if you look at this, these are the guidelines going back to, you can see 2015, 2017. And if you start on the left and you look at EASL, in the middle is ASLD, and on the right is the APASL guidelines. And what this paper very elegantly does is it shows us that if you look at people who develop liver cancer as a complication of chronic hepatitis B, based on 2017 EASL guidelines, a third of those individuals did not meet treatment criteria. If you look at APASL, so you're living in the Asia Pacific region following the APASL guidelines, almost 2/3 of individuals did not meet treatment guidelines. Now, as a clinician who manages and sees people living with chronic hepatitis B all the time, I will tell you in very clear terms, this is a failure of treatment guidelines that we're not treating people and they're developing liver cancer. Next slide, please. And over the last, I would say certainly really mainstream chronic hepatitis B field for the last 5 years, 10 years, for someone like Thomas and myself and John, who are kind of very much involved in the basic science of hepatitis B, we've always recognized integration. It's gone back for a very long period of time, but certainly it's come very much to the fore in recent years, probably around the whole functional cure program. But if you look at the top of this slide, what I'm showing you is the classical cccDNA, pregenomic RNA, the viral reservoir leading to inflammation, fibrosis, cirrhosis, and liver cancer. That's the paradigm of liver cancer development in that indirect fashion of liver injury. But on the bottom of this slide is also HBV DNA integration, and that's also in its own right a significant driver for the development of liver cancer. So we need to think about this when we approach the management of chronic hepatitis B, because essentially there is more than one process which is in motion here, and we need to consider that in terms of treatments and how we manage individuals living with chronic hepatitis B. Next slide, please. So this brings me to the recent ICE-HBV publications, and really this is just a simple cartoon highlighting to you where we are in terms of management of chronic hepatitis B. So on the left over here again, we're looking at the burden of chronic hepatitis B that we face, 254 million people infected globally. As you move across, you're seeing 34 million people diagnosed, and you move across to the right to the clinic, to this lighter green shaded area, and you'll see that only 6.6 million people that currently we estimate are on treatment. This is less than 3% of the global population with chronic hepatitis B. Now, this is certainly a failure in terms of diagnosis, treatment, and management of chronic hepatitis B. But more worrying, if you look at the top of this slide where I've included this publication from the Lancet a few years ago, and I include this quite a lot because it compares 2016 estimations around years of life lost and deaths from chronic hepatitis B with projected numbers for 2040. And if everything remained unchanged from 2016 or even now, we would see a doubling of deaths from chronic hepatitis B by 2040. So this is really a stark warning for us that, if we just leave things the status quo, this is certainly not going to help us and is certainly going to lead to more deaths from chronic hepatitis B, which could be avoidable. At the bottom of this, under the x-axis, what I'm showing you here are some of the complicated elements of management, diagnosis, bringing people to clinics, bringing people to hospital, more tests, more monitoring, go away, more tests, more clinic visits, without actually moving forward to treatment. And this is something we always also wanted to highlight in the recent ICE-HBV papers. Next slide, please. So this brings me to the classical disease phases of chronic hepatitis B. And this is something that I've, as a clinician, as a translational hepatologist, have been working on over a number of years now. And if you start again on the left, you're looking at e-antigen positive chronic infection. This was formerly referred to as immune tolerant. Then e-antigen positive chronic hepatitis, formerly referred to as immune active. Then you get the e-antigen negative chronic infection. This is what we would consider immune control, and e-antigen negative chronic hepatitis on the right. And these are the four phases, if you want. Let me draw your attention to the bottom of those disease phases. And just look at phase 1 and phase 2. You will see the cccDNA, correlated antigen, serum HBV, and large surface antigen. These are identical between these two disease phases. And you might say, okay, that's fine, that's just the virology. But previously in immunology studies and work that I've done with Antonio Bertoletti, we've shown that this e-antigen positive chronic infection or e-antigen positive chronic hepatitis are also the same immunologically. So why would we treat patients who are labeling as e-antigen positive chronic hepatitis by virtue of a change in their ALT, but not treating those e-antigen positive chronic infection? And really the ICE-HBV papers were to delve into these inconsistencies and really bring them to the fore and ensure that they were part of the debate as we move forward in terms of treatment guidelines and also in terms of treatment as we move forward to functional cure. Next slide, please. So if you're to ask me in my position where I see things in the field, I'd say the rationale for expanding treatment is obviously reducing the risk of liver cancer, and this will reduce deaths, and of course it will improve quality of life, exactly as John was saying. So let's move to the next slide, please. And this is some of our, the slide back. This is some of our work, back again, thank you. This is some of our work with Bill Mason a couple of years ago. And what I'm showing you here is that when we look at patients on the top left of this slide, you will see the patients as young as 15, 17, 18. These are patients labeled as immune tolerant, but they already have clonal hepatocyte expansion. Clonal hepatocyte expansion essentially is one of the mechanisms involved in the development of liver cancer. So essentially, when we're studying these individuals and we're studying patients in their teens up onto people into the 30s and 40s, we're able to study, by studying the liver, measure integration, measure clonal hepatocyte expansion, and see across these different phases how these people are in their liver in terms of the consequence of chronic hepatitis B. And if you look at the bottom of this figure, you will see those individuals who develop HCC are those with the biggest clones when you study them. So we want to affect the chronic hepatitis B to mitigate the development of liver cancer and also to reduce this clonal hepatocyte expansion and reduce this integration. Next slide, please. Again, this is us looking at the other end of that spectrum. So moving away from the e-antigen positive phases of disease to the e-antigen negative phase of disease is where, many more patients are in these phases. And if we just move forward to the animation on this, what I'm showing you here is patients with much lower levels of viral load, even those patients with less than 2,000 IU. What we're seeing in these individuals actually is that also there is integration, and by virtue of that integration, we're also seeing the potential for liver cancer in those low viremic patients. So we have to be careful that we're not falling into some trap in terms of disease management, thinking that people who have a low level of viral load, normal liver enzymes, that they are excluded from this pathway of integration and the potential for the development of liver cancer. If we can just move forward just briefly there. Yeah, and there I'm showing you that when you get down to these very low levels of viremia, less than 2,000, 2,000 to 20,000, greater than 20,000, yes, we're seeing differences virologically. We're seeing differences in terms of the viral reservoir, but even those low viremic patients harbor integrations, and those integrations can have impacts, showing you in the top right-hand box here in terms of drug metabolism, lipid metabolism, the immune response, and important elements that we would associate with disease progression. Next slide, please. And again, I just touched on this earlier. We talked a little bit about the immunology studies, and this is a study, in fact, that I published with Antonio Bertoletti a few years ago in gastroenterology, and it's a really big study where we study in depth almost 250 patients, studying their T and NK cell responses, studying basically their global immune response. If we just move to the animation, please. a very simple takeaway from you here. If you look at the bottom panel here and you look at these donut plots, if you look at the orange plot that seems to disappear after the age of 34 with that third donut plot, that essentially is the disappearance of the envelope-specific response. So essentially, when you get to the age of 30, you lose one line of your defense in terms of your host immune response. And this is a very simple concept. We're saying, well, most guidelines say start treatment after the age of 30, but we're just showing you that after the age of 30, you're already losing some of your host immunity, that if we treated patients much earlier, we would capitalize on a more functional host immune response. These are very simple take-home messages. And this is something which really we need to understand in terms of how we move forward in terms of changing the way we treat chronic hepatitis B. Next slide, please. So what is current clinical practice? What are the current international recommendations? And how is ICE-HBV and these two important papers really impacted this? How have they pushed the envelope a little bit more? I'm going to show you now. Next slide, please. These are the recent updated WHO guidelines, the recent Chinese guidelines. And what I want to show you here, I want to draw your attention to something really, which is, I think, is stark, but it's very important, that there's no barrier to treatment here with WHO. If you start with treat all adults and adolescents, that's important. You got to get down to the bottom right-hand corner box here, which says defer treatment and monitor. This would only be in individuals with a DNA of less than 2,000, with persistently normal ALT, with essentially no other worrying factors which could be associated with disease progression. Remember, there's a subset of individuals who are very safe with very low levels of viremia who do not progress. And we have to also recognize that. And that's part of the balancing of the management of individuals living with chronic hepatitis B. Look at the Chinese guidelines. And very interesting, again, this is really dropping the threshold for offering treatment. So you're surface antigen positive, you've got detectable DNA. Remember, there's no threshold, there's no over 2,000 here, but you've got detectable DNA. Move down into the center box, even if your ALT is normal, so you've got detectable ALT, your ALT is normal. If you're above the age of 30, you should have treatment. And then any of these other potential risk factors, family history of HCC, evidence of fibrosis, HBV-related extrahepatic manifestations. You can see the bar has been dropped in terms of offering individuals treatment for their chronic hepatitis B. And next slide, please. And this is my final kind of slide in terms of my presentation. It finishes with the EASL clinical practice guidelines published this year at the EASL meeting, and really important because the EASL guidelines, I think personally, I was part of the EASL clinical development group, and the work within ICE-HBV, the work that was going on in parallel, the papers that were being published were certainly moving our thinking forward in terms of how we would produce a guideline, which we think is a very comprehensive guideline in terms of management of chronic hepatitis B. But in principle, I'm just going to leave you with this one sentence: all surface antigen positive individuals with detectable HBV DNA are candidates for antiviral therapy. If you ask me, as a clinician treating individuals with chronic hepatitis B in the clinic, this is what I want to see, because this empowers individuals living with hepatitis B, it empowers the healthcare practitioners, and together we can say, yes, we can treat more people because we know the potential complications of chronic hepatitis B. Next slide, please. So that leaves me with my take-home messages. I think John covered this very succinctly to begin with the kind of opening up and showing us why these papers were first written. But simple take-home, look at those ICE-HBV papers, look at that figure I showed you with the numbers and on-treatment patients. We need to diagnose more people living with hepatitis B, and we need to treat more people. Simple take-home message. John covered the fact that nucleoside analogs are highly effective, they're safe, they're affordable. There's no good reason that we're not using them much more in our clinical practice. We know from very good studies, we know from all the studies, the registration studies and beyond, nucleoside analogs can reduce viral suppression. People can be fully virally suppressed on nuke, reverse fibrosis, normalize ALT. Now we're beginning to see some data emerge that nukes can also reduce HBV integration and clonal expansion of hepatocytes, which is an important element, an important subject, which clearly will need more research as we go forward. Expanding treatment will reduce the complications of chronic hepatitis B, including the development of HCC. And clearly, that is something that we need to be thinking about when I showed you those projected numbers for 2040. And then finally, something that I've talked about for a long time, we've got the functional cure program, and people think miraculously we're just going to have drugs in our clinic that we're going to be curing people. Unfortunately, the real world is not like that. I think we're still quite far away, and we're going to be very far away from people all over the world being able to access new therapies. So really, I think the concept of putting individuals, putting more people on nucleoside analogs early, and this is what I would describe as a bridge to functional cure. Put people on nukes, suppress their virus, normalize their liver enzymes, potentially reduce integration, clonal hepatocyte expansion. They're going to be safer, and then access functional cure studies from there. Thank you very much for your attention.
Thank you so much, Dr. Kennedy, for that clinical overview of the justification for treatment expansion. That was an excellent presentation. Now I would like to turn it over to Dr. Sherry Cohen, who will be discussing the patient and public health perspectives to inform the expansion of treatment guidelines. Sherry, over to you.
Great. Thank you so much, Catherine. And thank you, Patrick, for leading the way, and John for sharing an overview and of how the papers happened. And I'm happy to talk a little bit about the public health and patient perspective towards expanding treatment. Next slide. Thank you. So there's been a recent shift toward expanding treatment eligibility to initiate antiviral therapy earlier and for more people. And as Dr. Kennedy just showed, that we have had some medical and professional society guidelines expand their treatment recommendations by lowering eligibility requirements, and importantly, by including patient preference and shared clinical decision-making to guide treatment discussion and decisions. There's also, at the same time, a movement to align eligibility criteria across the world and to simplify guidelines to make it easier for both clinicians and patients, and to help better enable decentralization of care. This is really good progress, but we still have a ways to go. And I'm going to highlight a little bit of the patient and public health rationale for expanding treatment. Next slide. Over the past 10 years, we have grown a fairly substantial body of evidence that shows that chronic hepatitis B is associated with significant quality of life impact, even in the absence of liver disease and liver damage. So this includes physical, emotional, and social impact that influence every aspect of life, including familial and professional. So physical impact, we often hear and document unrelenting, debilitating chronic fatigue, pain, muscle aches, and these impact productivity, ability to care for children, for example, and ability to pursue professional and lives and higher education. Emotionally, we are able to document people feeling increased and ongoing anxiety, fear, and stress. So this is primarily related to worry about liver cancer and premature death, but also transmitting the virus to others, not being able to access or afford lifelong care and treatment. So it is important to note that, when we look at these quality of life impacts, these are not regularly assessed or recognized by clinical management through clinical management of hepatitis B. And so that's something that really, it makes us feel over time that hepatitis B is a silent disease, when it's just that we're not necessarily asking the right questions and asking people to talk about how hepatitis B is impacting their lives, even if they don't have cirrhosis or liver cancer. Next slide, please. To give a little bit of example of how we're quantifying quality of life, and this shows here, this is results of a study that the Hepatitis B Foundation conducted in 2020 using an online survey. This was almost 2,000 people from about 20 countries. And we asked people to rate how much the different physical, social, and emotional aspects of living with hepatitis B were challenging to them. And then we created indices that described the physical, the social, and the worry impact. And you can see here that 3/4 of the respondents felt a physical impact and a social impact, and about 1/4 of respondents felt a worry impact. And the other interesting thing was that antiviral treatment was associated with improvement in all 3 quality of life indices. Next slide. So now that we have a little bit of background on quality of life impacts of living with Hep B, let's look at some of the rationales for expanding treatment. We're going to start with the clinical rationale. There's evidence, and Dr. Kennedy touched quite a lot on this, but there's ample evidence that people who fall outside of treatment guidelines still develop liver cancer. In one retrospective study, they found that among people within a hepatitis B cohort who developed liver cancer, 46% of those who developed liver cancer would not have been recommended for treatment by AASLD guidelines. 64% would not have been recommended treatment by the APOSL guidelines. So that just gives an example. There's also evidence that suggests, new evidence that suggests that early treatment with antivirals, there was a study done on TAF, that reduces the risk of liver cancer, liver transplant, or death in people without cirrhosis who have moderate or high viral loads and normal or only slightly elevated ALTs. And then additionally, we have studies that show that long-term viral replication and DNA integration to drive disease pathogenesis. And Dr. Kennedy talked about this, and I know Dr. Thomas too can as well later on, but that also antiviral treatment can suppress DNA integration. So liver cancer, what we know is that liver cancer associated DNA damage occurs early on infection, and early intervention can likely be used to prevent it. We also have some small amount of data on non-hepatic malignancies related to hepatitis B infection. So we don't have a lot, there's limited data on this topic, but we have at least one study coming out of South Korea that found that complete viral suppression with long-term antiviral treatment reduced the incidence of non-liver cancers in some people living with hepatitis B. So based just on preventing cancer, the authors of the paper felt that expanding treatment guidelines was justified. Next slide. Moving on to quality of life, we've already talked a little bit about the quality of life impacts and the significant impacts of living with hepatitis B. So in addition to cancer prevention, we feel strongly that improving quality of life needs to be considered as an important reason for initiating treatment. And as I touched on a little bit before, in the space of hepatitis B, we have perpetuated this erroneous belief that Hep B infection is asymptomatic for people without cirrhosis. And yet when we document and we ask people what the impacts are, that is not what we're seeing. What we're seeing is that the hepatitis B quality of life impact career, livelihood, education, employment, relationships, immigration, and personal autonomy. And we also know that quality of life impacts are not typically consistently addressed or assessed in clinical settings right now. So we have a couple of validated instruments that we can use to assess quality of life. They're not consistently used, they're not included or recommended in the professional guidelines. What we also know is that antiviral therapy can help ameliorate the quality of life impacts. And when you take that evidence alongside data that show that people living with Hep B have reduced quality of life, even in the absence of liver damage, we have a very strong rationale from the quality of life perspective for expanding treatment eligibility. Next slide. Expanding treatment is also likely to limit transmission of hepatitis B, and importantly, it is likely to address some of the transmission-related anxiety. So what we know is that current guidelines advocate already for the use of antivirals to prevent transmission. And this is in two specific circumstances. One is preventing mother-to-child transmission, and the other is among healthcare workers who are living with hepatitis B who conduct exposure-prone procedures. Outside of these two situations, antiviral treatment is not recommended to prevent transmission. Instead, the focus has been on vaccination and on behavioral preventive practices. What we know is that this imposes a very heavy burden and can be impossible to universally implement. It's a huge responsibility on people living with hepatitis B. So we know that people feel burdened to ensure that everyone around them is vaccinated, to ensure that they know and are asking vaccine status of people around them, which very often means that they have to disclose their own status. There is a burden of perceived responsibility among people who are living with hepatitis B to refrain from participating in certain social situations, especially when they're unsure or feeling anxious about their risk. So treatment access for people who are seeking it would provide an extra layer of prevention, kind of like a safety net, to help individuals with hepatitis B feel able to completely and fully participate in life with less fear and less burden. Next slide. Reducing transmission is particularly important for adolescents and young adults. We know that most adolescents and young adults living with hepatitis B are not being treated despite having high viral loads because typically they fall outside of treatment criteria. Again, this poses a heavy burden for young people who are dealing with navigating things like disclosure and potentially facing stigma and discrimination and isolation at the same time that they're coming of age. So the WHO guidelines have expanded treatment recommendations to adolescents aged 12 years or older. This is definitely a positive advance that can help meet the needs of young people in this population. But we want to take it further. We think that we really need to reframe the discussion of treatment for young people, and that reframing this discussion should include the goal of reducing viral loads, and that might be very worthwhile in helping to move this forward. The other thing we want to look at is what we can learn from the tremendous progress that was made in the HIV community towards reducing both transmission, fear of transmission, and stigma. And that has been done primarily through using PrEP, through expanding treatment access to universal antiviral treatment, and through implementation of the U=U campaign, which is undetectable equals untransmissible. So basically that campaign says that when a person living with HIV maintains an undetectable viral load due to antiviral suppression, they cannot transmit the virus sexually through sexual contact. So a similar evidence-based message we feel could be very powerful for the hepatitis B space. And if we're willing to accept the fact that the risk of transmitting Hep B due to exposure to biological fluids is practically negligible during an invasive procedure where a provider has an undetectable viral load, then we need to consider and explore whether this might hold true for transmission during sexual contact in people who have undetectable viral loads as well. Next slide. Thank you. So changing treatment guidelines, of course, will need to be a part of wider public health response. And we did talk about what some of the implementation considerations would be. So of course, we would need to be building or expanding on new models of care delivery. We would need to talk about decentralization of services and task shifting to frontline providers. Also, potentially, we might have the need for different models of care delivery in different regions so that we can meet the specific needs of specific communities and build upon public health infrastructures that are already in place. We also should think about how we can include service integration. So, for example, things like antenatal care and adolescent care, service integration is already happening for hepatitis B and can be built upon. Next slide. Treatment expansion can also be used as a catalyst, and I think Dr. Kennedy mentioned some of this, but it can be a catalyst for clinical trials, for new drug development. It can increase the number of people who are eligible for clinical trials, especially for those clinical trials where antiviral suppression is necessary as an eligibility criteria. It can also help create demand, driving the market towards reduced rates, reduced costs for diagnostics and for treatment, and can help influence policies toward prioritization of hepatitis B elimination. I think that's something we see in many, many countries where hepatitis B elimination has not necessarily been prioritized, especially for funding. But when we talk about being able to drive treatment access, all of a sudden, I think that really could change prioritizations for policy. Next slide. Of course, the benefits of expanded treatment need to be weighed against risks. And we know that long-term adherence is very important right now with antiviral care. Incomplete adherence can lead to negative health outcomes. What we want to do and what we focus on in the paper is reframing the conversation about adherence from a barrier to an enabler, right? So where can we provide guidance to clinicians to help them manage adherence and support for patients to maximize adherence instead of thinking about, adherence is an issue, we have to be careful who we recommend treatment for. Reframing the question, how can we maximize adherence so that it is not a barrier to treatment? There are some other issues that we need to consider, of course, things like side effects. Treatment access is going to be a major issue that we're going to have to deal with. And what we don't want is to create this culture of pressure so that people living with hepatitis B feel that they have to start treatment. So there are certainly some risks and considerations we need to think about. Next slide. In the paper, we also discuss some questions that we need to consider as we're moving this forward. And so one of the things that I think we agreed upon is that time is of the essence. And right now, time, unfortunately, is working against us. So while we agree that there is still the need for data to help inform treatment-related decisions, we need to strongly consider what evidence we have now and what the public health and patient perspectives are now so that we can help save lives now, as opposed to waiting for data that we may never have in the future. Next slide. So just to sum up, the authors of this paper felt that there was strong public health and community rationale for expanding treatment eligibility for people living with hepatitis B. We need to consider the scientific evidence and the public health data and the patient perspectives right now so that we can make informed and reasonable and responsible decisions. And I think that is it for me. I just want to thank ICE-HBV for making this priority and thank the co-authors of the papers.
Great. Thank you so much, Dr. Cohen. At this time, I'd like to invite all of the panelists to share their videos, and we can start with some initial questions. I'd first like to bring in Dr. Tu and Dr. Wong to share if they have any initial reflections on anything that was presented or anything that you would like to add in addition to what was presented.
Yeah, I obviously agree with all of the points that have been made, being a co-author on the papers, but also I think what hasn't been mentioned has been what it does for the people living with hepatitis B in terms of empowering them. It removes this expansion of treatment eligibility. Removes just one barrier in terms of getting access to care, and it brings that person living with hepatitis B into the conversation a bit more. Instead of saying you can't have treatment or you should have treatment, it's you could have treatment depending on, what your risk appetite is in terms of liver cancer that may be coming up versus maybe side effects according or lifetime treatment. And that will be different for everyone. 300 million people around the world have hepatitis B, myself included. So this is also bringing in my own lived experience of hepatitis B into the conversation. So we can't make rules for everyone because everyone's in a different sort of boat. And so this enables treatment expansion, sort of enables that a bit more.
Thank you so much, Dr. Tu, and thanks for sharing your personal experiences as well. Dr. Wang, I wanted to bring you in to see if you had any initial reflections or additional comments that you wanted to bring into the discussion.
Thanks, Catherine. First, I want to say, John, Sherry, and Patrick, thanks for leading this. Thomas was actually on both papers, so he crossed this. But, I think it was really great to have these set of papers to bring up all the myriad of factors that we have all been talking about in various communities and spheres and put it all together and show that there's not just one or two reasons, like multitude of reasons. And I love how you all presented it. And I think it's really important. Hopefully a lot of people who are in the audience are people from the community, lived experience, because I think it's really important for when this data comes out that the people who are most affected are armed with this information. And as Thomas is saying, to be able to go there, and go to your physician who may or may not be a Hep B expert or be aware of this and say, ask for treatment. And I have to say, as a physician, I'm a primary care doctor. There's very few times when a patient asks to be tested or wants to start something that unless it's dangerous for them, usually we're more likely to agree to it. So I do think that patient being empowered and proactive is really important. And so we hope that this information gets spread wide, especially amongst the affected community. And speaking from my own lived experience, I have had Hep B since as long as I know, in terms of I've known since college, and never fit the criteria. And it was actually not until I saw a lot of this data, which Patrick actually covered, about integration, about T cell exhaustion, about what happens with age. And I said, how come nobody's ever talked about this? Why? Like, this is concerning to me with somebody who has lived experience. But how come it's never been elevated enough to the point of guidelines, right? We have all this great research, John Tavis and all the basic science people are doing this. And when I talk to them individually, they say, oh yeah, that's very concerning. Like if I had Hep B, I might start treatment but we're not the clinicians. I felt like I was listening to all these conversations about concerning things that happen with Hep B. And yet as somebody living with it, I was like, but why aren't we saying we could do something? Like, why can't I do something about this? Right. And nobody wants to do the wrong thing. Right. So I was like, well, I don't want to hurt myself by starting treatment. And I started asking people, and, there was nobody could say, oh no, something bad will happen if you start earlier. Right. Because that's what I wanted to know. If I start earlier, does that do something to my immune system? And I remember going to these meetings and asking people and like getting no good answer that if I started treatment, something bad would happen to me. And so if there's nothing bad that happens with starting treatment and I want to start treatment, why can't I start treatment, right? Instead of taking an herbal medication, which won't work, right? Which is what we see all around the world. People are spending lots of money on herbal treatments that do not do anything, right? They're promises, but there's no data behind them. So why don't we allow people to take the medications we know actually reduce the viral load, decrease inflammation? And when I started talking to other people, and Thomas and I are part of a growing community of people who are open about our experience. And it's really interesting how many of us have started taking treatment, even though we don't fall into the criteria. Some of us have been told everything's fine, but actually found later to have fibrosis or have, like what Patrick was saying, people who have fallen out, who are not don't follow in the guidelines for treatment, but yet already have these end stage outcome, bad outcomes we're trying to prevent. So not to say everybody will choose the same thing, as Thomas is saying, 300 million people all think differently. And I'm always surprised when I have patients who have on very similar tests. If I ask one person that the person I think is going to want treatment often doesn't want treatment, and the person who I think is definitely not going to want treatment is like, oh my God, I'm so glad you asked. Thank you. Yes, I do want treatment. So it is so important for the physician to ask, what is it that you want? And sometimes we think we're doing that without actually being explicit. So I think the focus on shared decision making, which EASL guidelines mention and the AASLD ones will also, is really going to be important for us to make sure the patient's part of that conversation. So thank you all for being, making this paper happen. And I'm so glad that ICE-HBV commissioned it.
Thank you so much, Sue. That I think is a really important point of giving patients the option and giving them the ability to have the information about treatment and what that might look like for them. We have a couple of questions in the chat, but before I get to them, I did have a question around the why and why current treatment guidelines exclude so many people from being eligible for the nucleoside analogs. And maybe that's something that Dr. Tavis and then maybe Dr. Kennedy can then comment on. And I'm sure others probably have some thoughts on that as well.
That has to do with how clinical guidelines are set. There is, a lot. Early on, treatment was kind of the Wild West. I mean, I'm talking about general medical treatment. Stuck in the 1900s, 1920s. I mean, whatever they thought might work, they did. And of course, there was no evidence backing it up. So as medical science advanced, there was a great push for evidence-based medicine. It has been a huge boon overall to the quality of care that people are getting. There's no question whatsoever about that. But that impetus has been expanded to the point where it becomes a mandate, and there is a recommendation or an expectation that the data that is considered fits a certain clinical study quality set or guidelines. And in the vast majority of cases, that's just the right thing to do. But with HBV, to get that quality of data, you would quite literally have to do a 30 to 40 year placebo-controlled trial of tens of thousands of people, because the endpoint would be hepatocellular carcinoma, advanced cirrhosis, or liver failure. Okay, that is both financially, logistically, and ethically impossible to do. So because of the characteristics of HBV, this really good tendency in the medical community simply doesn't apply to this disease. And that's one of the things we're trying to get across.
Thank you. Dr. Kennedy, anything to add to that?
Yeah, I mean, John couldn't have really, framed it any better than that. And I think that's really the key thing. The one thing I would add is that it's quite interesting because I think this is where ICE-HB really needs to be commended because, Thomas has done fantastic work. John has, Chari has, we have worked and produced novel findings, but working in silos. I think what these two papers did, they brought us together as people who are showing the evidence. And it's that evidence, basic science evidence, public health evidence, which is actually able to push that envelope a little bit more. And just one final thing to comment on, Sue talked about this concept of the shared decision making. As somebody who was in EASL, this came from the kind of opinion that was growing outside of it that we felt that just had to go in there. And I'm really proud that it is there. Of course, it'll come in ASL, but ASL is behind with everything. I mean, this is taken up and led by the European guidelines, and the bar has been lower. So, for the reasons that John said, guidelines have their weaknesses, but also with the community making, all of those kind of observations from the outside, they can push forward the field as we've seen happen.
Thank you. Any other panelists have anything to add to that? No? Okay. Another question that we have, I think maybe Dr. Cohen, you had mentioned the U equals U concept, and I know it's been discussed in a couple of different spaces as well. I know it's very prevalent in the HIV community for treatment initiation. Is that something, does treatment for hepatitis B and using nucleoside analogs reduce the risk of transmitting to others? Do we know that yet? Any comments?
Gonna let others chime in. What I will say is this, you're right. We've had a lot of conversations. There is, and I think, no one, I shouldn't say no one. We are not at a place where I think the evidence is there, where most people feel comfortable saying U equals U for hepatitis B. However, I think there's a lot of conversations and potential agreement among some that we may have enough evidence to say something similar, but maybe less strong. Low equals low. Like, I don't know exactly what it might look like, but I mean, it is really hard to disengage the idea that we're very comfortable preventing perinatal transmission and healthcare provider transmission using these same strategies, but we're not okay saying the same. I mean, if the science goes, then the science should fit, regardless of the situation. That being said, we know we need more data. I think the biggest issue with U equals U is I don't know that we'll ever have the data that we need to say U equals U. So the question becomes, and I'm going to throw this out to the other panelists, what might we be able to say now with the data we have now, or how can we come to some kind of consensus? Because I think this U equals U was transformative for the HIV community, and we want to see something similar happen.
Thank you. Anyone else have anything to add?
From a virologist point of view, I'd say it's pretty obvious that you have less virus, there's less chance of transmission, but I don't think the exact parallel with HIV will work is because on a specific infectivity, which means per particle, how infectious is it? HBV is more infectious. So as Sherry said, we're going to have to modify it a little bit, but the basic concept, I believe, is readily defensible.
Yeah, I think it's important for us to actually go with that. I feel like we've been talking about it and it'd be good to get out there because it is such an important message for patients to grasp. And even though we may say it's obvious, until I think we promote it, people still have that fear. Like, I have patients who have been undetectable and have been telling me they're still worried about, and Sherry, you and I have talked about, people afraid to carry their babies or like worried about giving it to grandkids or not wanting to date, right? So it really impacts people's lives, this fear of transmission. So I think we need to find our own term of it. It doesn't need to be exactly what HIV has, but we've got to, especially since there are people with such high viral loads out there too, and I think it's just showing that, lower equals lower risk of transmission, also lower inflammation. I think it's a nice package, right? All of that. So I think that messaging is important. And for HIV, when we talk about people who were there when U equals U started, it was not, even though now we say it's so obvious, like there was a lot of disagreement too. So, and they finally realized, rather than splitting hairs, because even when somebody's undetectable with HIV, you sometimes can have blips where there's still a little bit of virus. And so, but they decided the message was so important that U equals U was such a clear message that was important for health education and getting that across.
Yeah, this question comes up a lot on hepbcommunity.org, doing a little plug for the online forum that I run for people living with hepatitis B, as well as for experts to come in to provide a lot of information directly to the affected community. When I try to convey this risk, it's using the evidence that's available. For example, people who have a viral load giving birth, the lowest level that's ever been shown to transmit from mother to child during birth, where a whole lot of bodily fluids are being exchanged during that procedure, is this level. During sports, there has been no measured increase of Hep B transmission risk in Australian rules football, which is quite contact heavy, let's say. And all of these sort of studies that are not necessarily U equals U, but at least these are the sort of activities that do not convey measurable risk. So you're okay doing, this little scratch is actually really negligible risk. And I think John has been great as well, participating in this sort of forum and conveying a lot of those risks from a molecular biologist sort of perspective as well. And so thank you.
Thanks so much. We had a couple of questions come in through the Q&A around e-antigen. The first is from Dr. Fofana, who's in Mali, and noted that many African folks are e-antigen negative. Is there any explanation, especially if it's important to treat e-antigen individuals?
I mean, I'll just give a very very brief response. I think in this case, what you will see, even in the WHO guidelines, certainly a move away from those classical disease phases, which are essentially based around e antigen positive, e antigen negative. The reason for this is, for many years, people have talked about guidelines being overcomplicated, difficult to interpret, and really there's been a major drive to reduce some of the mystique surrounding chronic hepatitis B. And one of those is that, it's quite simple. If you listen to Thomas or John or Chari or Sue, if there's evidence of viremia, we're treating the virus. And I think that's a really important point to move forward with. And you will see that's really, I think, where the field has moved a lot. We could have a lot of conversations about e-antigen positivity and the virus, cccDNA, integrated DNA, or e-antigen negative chronic hepatitis B with mutated virus. But the bottom line is, if there's detectable viremia, we want to lower the barrier, treat more people. So I don't want to get too caught up in a discussion around e-antigen.
Great, thank you. And my last question, because I think it's related, would greatly expanding treatment eligibility allow for treatment to become more affordable? I think access, Dr. Cohen, you mentioned, is a really big issue. Is that something that you could foresee becoming easier for folks?
If anyone else wants to tackle, this is a tough one. I mean, I think it's almost chicken and egg kind of question, right? And it's pretty circular, but you can make the case that it, and we did have these discussions in the WHO guidelines committee, right? When we were thinking about expanding treatment, what would happen tomorrow if we recommended treatment for everybody? Where's the stopgap going to be, and who's going to be able to access and not access? So you can make the case that that access is a barrier, or you can make the case that driving expansion, driving treatment will reduce barriers to access and will actually drive access. From a market perspective, demand is usually what takes precedent, right? So demand drives cost and cost reduction, and would force potentially put us and the industry in a position where we were forced to provide access. And maybe that's what we need. Maybe that's the kind of transformation that we need to drive change. I don't know how others feel about it, and I'm not a market access expert, but to me, it seems like it would make sense.
Yeah, no, I agree. I think expanding access is definitely, we shouldn't use cost as a reason not to offer it. I think that more people wanting it does the demand helps. I mean, we know that it's helped in a lot of other disease states too, right? I mean, I think demand and also just activated patients, louder voices demanding access to treatment, it helped a lot with HIV and cancer treatments and things like that. So we should definitely, if we think it's something beneficial and more people should have it, I think that's what, that we need to do that. And it allows for, one of the things is making sure that we have providers, right? And I think, Sherry, you talked about decentralized care and making sure that our primary care providers can treat, and we have to get these guidelines simpler. And the EASL guidelines have like a really nice little simplified diagram, even though it's a very thick guideline of words, but the actual diagram itself is actually really easy to follow. So I think having that will equip and enable our frontline providers to be able to offer treatment to more people. So yeah, I think that that's going to be a key thing.
Okay, thank you. Oh, Thomas, I see you went off mute.
Yeah, I just want to say that these prices are elastic. We see even in particular contexts. So HIV is treated with the same drugs, and in some contexts, if you have HIV, those treatments are cheaper than if you have hepatitis B. So as Sue mentioned, these prices shouldn't be a barrier to actual implementation of getting these drugs out there.
Thank you. Yeah.
No, and I think we should make sure everybody knows that there are generic now, right? And that's one of the reasons the landscape has changed. I think one of your questions, Catherine, was like, why were they so restrictive before, right? Well, before the meds were expensive. There was worry of resistance, right? And now we have medications that have, that we don't see resistance in and are now generic. So it is a lot more affordable. And so, I mean, even in the US here, I just had a patient this week told me he was able to get his entecavir for 6 months. It was $60. So it was $10 a month, which in the US is like the cheapest I've ever heard of it. It used to be more expensive than tenofovir, and it's actually cheaper now. So I think we got to keep spreading the news, because at least in the US, if you use insurance, you may still face a lot of barriers, where there's still prior authorization. They may say it's not on the formulary. They may say crazy things like you should go on lamivudine first. So this is why it's so important for patients to be educated, right? Because there's little things like this that you can find out where you can you can access your meds a lot cheaper than what their insurance might say.
Yeah, definitely. And I'll echo, you can get educated if you are someone with lived experience through the Hep B community. That's a huge forum where you can get information. You can also look at the Hep B Foundation's website or reach out to info@hepb.org for a direct, if you have a specific question about your own experience as well, you can get more information there as well. I want to, given that we are just a little over time, I want to just give it a round if anybody has any final closing remarks that they want to share, final reflections from the panel. I can open it up.
I have to say how grateful I am to be able to participate in this. I've studied hepatitis B virus since the early 1990s, and to see us having this conversation where we have really practical, straightforward means, by which we can help more people really, really gives me a good feeling. And to know that I was involved in helping to launch writing of these two papers makes me really happy because I really want to just help folks.
Thank you. Well, thanks for being here and sharing your knowledge with us. Dr. Tu?
Yeah, I just want to say thank you to the whole sector of experts, but and also for involving the lived experience and patient voice in a lot of these conversations. And I am really buoyed by the changes in attitudes and the openness within the whole field on sort of making sure that the lived experience is centered in a lot of these conversations, and I hope this continues.
Thank you. Great. I don't see any others coming off mute. So I think Dr. Tu's message is a good one to leave us on. And I think this is really, the start of many future conversations as well. And we still have a lot of work to do in the hepatitis B space to really make sure treatment is accessible. And we're thinking about expanding guidelines not only in more Western context, but also in contexts all over the world, because we know hepatitis B is a global disease that impacts so many people around the world, and we have a lot of work to do to reach those WHO elimination goals. So I want to take a minute to thank you, the audience, for joining us today. We'll follow up to all registrants in the coming days with a recording of the session, and it will also be available on our YouTube page within the next week. Thank you again to our wonderful panelists who have spent their time and expertise with us today. We appreciate all of their contributions to this excellent discussion, and we look forward to future conversations on this topic as well. And we hope that everyone has a good rest of your evening, and thank you all again for joining us today. With that, I will go ahead and conclude today's session. Thank you all.